Chapter 9 covers common injuries to the abdomen and thorax, as well as general medical conditions. Athletic training falls under the larger umbrella of sports medicine. Sports medicine is defined as a field of medicine that uses a holistic, comprehensive, and multidisciplinary approach to healthcare for those patients engaged in a sporting or recreational activity. The comprehensive approach includes the physiological, biochemical, psychological, and pathological phenomena associated with exercise and sport. The clinical application of these disciplines is performed to improve and maintain functional capacities and includes the prevention and treatment of diseases, as well as injuries related to exercise and sport. Pathological, psychological, and prevention and treatment of diseases are included for a good reason, and each reaches far beyond just the treatment of injury. Athletic training as a component of sports medicine must address all of these issues. Athletic training professional programs will need to put greater emphasis beyond the orthopedic components of athletic training and strive to learn as much as possible about the medical illnesses and conditions frequently seen among populations we serve. Prior to exploring some of the common general medical conditions with which the athletic trainer must be familiar, it is beneficial to discuss a key event that must take place prior to athletic competition. The pre-participation examination, or PPE, is designed to protect the safety of participants. Athletes who participate in athletics in both secondary, school, and collegiate settings are required to have PPEs. The National Federation of State High School Associations stipulates that a student may not practice or participate in interscholastic athletics until the school has written evidence of permission to participate in sports as determined by a physician or an advanced practice nurse prescriber. Intercollegiate athletics are required to have a PPE upon entrance into college. This initial evaluation should include a comprehensive health history, immunization history, and relevant physical examination with strong emphasis on the cardiovascular, neurologic, and musculoskeletal evaluation. Subsequent to the initial medical evaluation, an updated history and medical review should be performed annually. The primary goal of the PPE is to detect any conditions that may limit the athlete's participation and predispose the athlete or others to injuries or illnesses during competition. Secondary goals are to determine the general health of the individual, assess fitness levels, and counsel the athlete on health-related illnesses. The PPE is often the only involvement many students have with the healthcare system, so it is important that examiners make this encounter as comprehensive as possible. An important function of the exam is to determine athletes who are not only at risk for general medicine and orthopedic conditions, but also to provide guidance on psychosocial problems including sexuality, substance abuse, violence, or any other emotional or psychological factor. A well-constructed PPE is more likely to identify these types of problems in adolescents more so than in danger of cardiac problems that will lead to sudden death. The nature and style of administering the PPE will strongly influence its value. PPEs should be done 6 weeks before the start of the season. This allows any problems that may exist to be addressed. There are two primary styles of PPE that can be arranged: the office-based examination and the station-based examination. In the high school setting, many athletes will see their personal physician for their PPE. However, given the range of insurance coverage and economic need of many students, it is equally common for local high schools or sports medicine clinics to sponsor station-based exams as a community service. The station-based examination is common in the intercollegiate setting, given the number of athletes reviewed annually, which is the main purpose for this type of exam. In station-based exams, athletes move from station to station in separate rooms or spaces to ensure privacy to complete the exam in a timely fashion. Regardless of the type of exam, all PPEs should include the following: a general health screen, cardiovascular screen, neurological screen, orthopedic screen, and a general medical screen. A detailed example of the PPE is found on Table 9-2 on pages 214 and 215 in the textbook. The scope of this introductory text does not allow for an in-depth presentation of all the possible medical conditions the athletic trainer may encounter, so the most common conditions will be covered. Keep in mind that this is just the basics of what an athletic training student will need to know before preparing themselves to sit for the BOC examination. The respiratory tract is defined as all of the mucosal covered surfaces located above the level of the vocal cords. These surfaces are subject to a variety of infections caused by viruses and bacteria. The lining of the upper respiratory tract is covered with cells that produce mucus. This mucus serves as a necessary function in lubricating the tissue and trapping particles. Common signs and symptoms of illness that affect the upper respiratory tract are stuffy nose or runny nose, fullness in the head, and irritation of the throat. The common cold is caused by a variety of viruses. Colds tend to appear during the winter season, and despite myth and folklore, it is not the cold weather that causes the spread of cold viruses, also known as rhinoviruses. Contaminated respiratory secretions spread colds from person to person, either by the inhalation of airborne particles or direct contact with virus-laden surfaces. In addition to the previously mentioned signs and symptoms, sneezing, low-grade fever, sore throat, and cough may indicate a cold. These signs and symptoms usually last for about a week, but if not taken proper care of, may linger longer, especially a cough. There is no cure for the common cold, but rest, the use of a humidifier, and medication to treat the symptoms, not the illness itself, can be helpful during recovery. Influenza is also a common winter problem caused by a specific type of influenza virus. Unlike the common cold, using a vaccine prior to the winter flu season can often prevent influenza. Influenza is spread by respiratory droplets and contact with contaminated objects. Signs and symptoms include fever and chills, headache, and muscle aches. Treatment includes pharmacological intervention within the first 24 to 48 hours, rest, and fluids. Sinusitis is an inflammation of the nasal sinus membranes. A range of different bacteria can cause this illness, and signs and symptoms include nasal discharge, pressure in the sinuses, and headache. Treatment options for sinusitis include antibiotics, symptomatic care with over-the-counter or OTC medication, saline nasal washes, and steam treatments. Asthma is a lung disease that affects millions of people. If left untreated, complications from asthma can be fatal. Asthma has the following characteristics: bronchospasm, which is an airway obstruction that is reversibly spontaneous or with treatment, airway inflammation, and increased responsiveness to a variety of stimuli or stressors. Stressors may include respiratory tract infection, emotional stress, allergens, cold air, hyperventilation, and irritants like smoke and smog. Asthma results in a decreased ability for oxygen to be exchanged due to increased mucus production and spasms causing the narrowing of the airways. A few of the signs and symptoms of an asthma attack include intense labored breathing, spasmodic coughing, chest pain and tightness, and wheezing. Care for an asthma attack should include the following: attempt to relax the patient, use of a previously specified medication if cleared by a physician, and having them perform controlled breathing and relaxation exercises. Exercise-induced asthma, or EIA, and exercise-induced bronchospasm are airway diseases in which exercise or physical activity acts as a trigger to asthma symptoms. EIA can occur in a patient who have no previous history of asthma. Signs and symptoms include repetitive cough and/or slight wheezing either during or after intense exercise. Treatment may include the use of a prescribed bronchodilator or metered dose inhaler and may involve gradual warming up and, if possible, avoiding environments that trigger the reactions. Pharyngitis is a sore throat associated with nasal symptoms or sore throat as a result of a primary infection. Both viruses and bacteria can cause sore throats. They also can be seen with mononucleosis, influenza, common colds, and other illnesses. Treatment for bacterial infections include a course of oral antibiotics. Viral infections will not respond to antibiotics and must be treated with rest and the reduction of major irritants that cause increased signs and symptoms. Otitis externa is also known as swimmer's ear and refers to general inflammation and infection of the ear canal. Swimmer's ear is caused by exposure to water that contain various organisms, especially hot tubs. Patients with this condition will complain of ear pain and an itching sensation. A gentle tug on the ear can produce pain, and examination of the ear canal can reveal redness or pus in the ear canal. Treatment can include topical antibiotics or anti-inflammatory drops. If the infection has spread beyond the ear canal, it may require oral antibiotics. Otitis media is an infection to the middle ear. Middle ear infections result in a collection of fluid behind the tympanic membrane or eardrum. Signs and symptoms include ear pain, difficulty hearing, headache, fever, and nausea. The patient must be referred to a physician, and treatment includes rest, pain control, and antibiotics. Mononucleosis, also referred to as mono, is an acute infection that is caused by the Epstein-Barr virus. The virus is carried in the throat and transmitted in the saliva, thus its reputation as the kissing disease. Adolescents and young adults who live in close quarters and share utensils are commonly at risk. Initial signs and symptoms may include fever, sore throat, swollen lymph nodes in the posterior neck, loss of energy, and muscle aches. Symptoms can last for up to a number of weeks, especially lethargy. Additionally, mono can produce an enlargement of the spleen, thus creating the chance of a splenic rupture. Treatment of mono requires rest and treatment of symptoms. Meningitis is an infection of the covering of the brain and spinal cord. It can be caused by a bacterial meningococcus as well as a number of viruses. The infection can present similar to cold symptoms and may sometimes resemble the flu. However, it can progress to an infection of the blood or full-blown meningitis very rapidly. Bacterial meningitis is serious and can be very deadly. College-age students living in close quarters are considered a high-risk group from meningococcal infections and should be vaccinated. Meningitis is spread by droplets or direct contact with an infected person. The symptoms to look for include the following: high fever, nausea or vomiting, severe headache, stiffness and pain in the neck, and a skin rash of a small purple or red-like spots on the skin. If symptoms appear suddenly, refer to a physician, especially for a high fever and neck stiffness. Skin infections are a common occurrence with athletes and physically active individuals. Many sport activities require lots of equipment that can become dirty and easily contaminated. In addition, the close contact required for some sports, such as wrestling or boxing, make athletes more susceptible to skin-related problems. The most common skin infections are caused by fungi, viruses, and bacteria. Fungal infections are very common in athletic and sporting events. Tinea is a group of fungi commonly associated with ringworm. Ringworm is the name for the red ring that appears when a fungus is present on the body and is named based on the location of the fungus. Tinea corporis is tinea of the body, or ringworm. Tinea pedis is tinea of the feet, or athlete's foot. Tinea capitis is tinea of the scalp. Tinea cruris is tinea of the groin or jock itch. And tinea unguium is tinea of the nail bed. Signs and symptoms include redness and itching, with treatment of over-the-counter or prescription fungal medication, including powders and sprays, can help alleviate these signs and symptoms. The most common viral infections seen in athletic populations are the herpes group of viruses. Herpes simplex 1, which is responsible for cold sores and fever blisters, and herpes simplex 2, which is responsible for genital herpes. These viruses are opportunistic and can appear during times of stress or when the host is fatigued or ill. Outbreaks result in a tingling sensation followed by an outbreak of fluid-filled vesicles. While medications can be used to treat the outbreak and lessen their severity, the viruses will not be killed and can return. Over-the-counter topical creams and oral antiviral medications can be used to treat the signs and symptoms during an outbreak. Herpes virus can be spread with contact during an outbreak, and thus the universal precautions must be practiced at all times. Bacterial infections can be seen among physically active individuals as well. These pus-producing infections of the superficial layer of skin include the following: impetigo contagiosa, folliculitis, furuncles, and MRSA. The most common culprits to bacterial infections are streptococci and staphylococcus bacteria, often secondary to a wound that has not received proper care. Impetigo contagiosa warrants specific discussion because it is highly contagious and is frequently seen in children or athletes that have close skin-to-skin contact. The infection presents as a group of skin erosions with honey-colored crusts on them. This crusting is a characteristic of impetigo infections. Other bacterial infections may be characterized by redness, warmth, swelling, and other inflammatory signs and symptoms. Treatment requires the use of topical antibacterial agent or the use of systematic antibiotic. Methicillin-resistant Staphylococcus aureus, or MRSA, is a type of staph infection that is proved to be resistant to several common antibiotics. MRSA was traditionally used as a hospital pathogen. However, it is more commonly found in other community settings and now is described as either hospital-associated MRSA or community-associated MRSA, which is more targeted to the athletic population. Infections are facilitated by turf burn abrasions, chafing, shaving, prolonged physical contact, and the sharing of towels and equipment. Clinically, MRSA presents with skin and soft tissue lesions that an estimated 70 to 80% of the infections, and most of these infections are a mild form of skin lesions such as folliculitis, impetigo, furuncles, and other skin infections. Management is determined by the clinical presentation and may involve drainage of abscesses or treatment with oral antibiotics. Severe cases can require hospitalization. The female athlete triad is a syndrome that occurs in physically active girls and women. The triad historically was defined as the interrelated components of disordered eating, menstrual irregularities, and bone health, i.e. osteoporosis. However, a new model of the triad has been put forth in recent years. In 2007, the triad was redefined as a syndrome of low energy availability with or without disordered eating, functional hypothalamic amenorrhea, and osteoporosis. This is also known as relative energy deficiency syndrome, or REDS. Energy availability is defined conceptually and behaviorally as the amount of dietary energy remaining after exercise for all other physiological functions each day. At the healthy end of the model, each component is optimized. At the unhealthy end, each component presents the clinical endpoints of the syndrome, including low energy availability with or without disordered eating, functional hypothalamic amenorrhea, and osteoporosis. Female athletes often present with one or more of the three triad components, and thus early intervention is essential to prevent its progression to clinical eating disorders, amenorrhea, and further bone health issues. In addition to the physical components of sport and activity, an athletic trainer, as part of an interprofessional sports medicine team, must have basic understanding of the psychological effects they may have on a student athlete or patient. An athletic trainer must be prepared to facilitate the referral or guidance for psychosocial crisis by implementing intervention strategies to meet the needs of the patient. These issues may stem from a variety of sources, such as stress, family issues, depression, sexual identity issues, conflict resolution difficulties, and a host of other possibilities. An athletic trainer should know who their referral sources are, whether it be on campus or in the community, and work closely with them to establish a plan for assisting patients with psychosocial issues. More of this will be covered in future courses during your athletic training education. The abdomen is divided into 4 quadrants. Please familiarize yourselves with the quadrants and begin learning what organs are housed in each quadrant. Knowing where the organs are located can help an athletic trainer orient themselves if there is an injury to one of the internal organs. Layers of muscle and soft tissue protect the abdomen. The nature of this anatomical arrangement makes the region susceptible to muscular strain injuries as well as contusions. While most contusions are minor, trauma to the region can result in an injury to internal organs. The spleen is the most commonly injured abdominal organ due to sport-related trauma. The spleen is located in the upper left quadrant and is protected by the lower ribs. The spleen stores red blood cells and is responsible for producing antibodies and white blood cells. Some illnesses, like mono, can cause the spleen to enlarge and make it more susceptible to trauma. The mechanism of injury for an injury to the spleen includes a direct blow to the upper left quadrant. Other mechanisms can include fall or landing on an object over the area. Signs and symptoms of a splenic injury include, but are not limited to, upper left quadrant pain, nausea and vomiting, signs of shock, signs of abdominal bleeding, which can include abdominal rigidity and tenderness, and radiating pain to the left shoulder, also known as Kerr's sign. If a patient displays any of these signs, they should be referred to for immediate care. The kidneys are susceptible to contusions as a result of direct trauma from sport, such as boxing and football. The mechanism of injury involves a direct blow or blunt trauma. The patient may report a deep ache in the lower back and muscle guarding with hematuria, or blood in the urine, which also may be present. Care of a contused kidney may involve hospitalization for observation and gradual fluid intake. If the bleeding is severe, surgical intervention may be needed. Injuries to the liver are rare, but when they occur, it is typically a result of direct trauma to the right side of the rib cage. The liver may become contused or lacerated and is usually secondary trauma to injuries to the ribs. A patient with a liver injury may have pain and tenderness in the upper right quadrant. However, pain may refer to the chest and shoulders. Suspected liver injuries require immediate referral. Acute appendicitis is a common illness that affects the abdominal region. It is common in younger adults and presents with pain in the lower right quadrant, low-grade fever, nausea, vomiting, and pain that increases with walking and coughing. Palpation over McBurney's point may reveal point tenderness or rebound tenderness. The inflamed appendix can rupture if not treated, which could cause an infection to the entire abdominal cavity. As with any abdominal pain, prompt referral to a physician is in order. The organs of the thoracic cavity are well protected by skeletal arrangement of the rib cage. However, injuries to the internal organs can take place, and injuries to the musculoskeletal structures that protect those organs are commonplace. In sport and physical activities, direct blows, falls, or contact with an implement like a ball or a bat can cause injuries to the ribs, surrounding structures, or internal organs. As the heart and lungs are contained in the thoracic cavity, injuries to this area can be life-threatening. Possible serious internal injuries in this area include pneumothorax and cardiac contusion. Common musculoskeletal injuries include contusions, sprains, and fractures to the ribs and sternum. A pneumothorax occurs when air is allowed to enter the pleural sac that surrounds the lungs. The entrance of air into this cavity will cause the lungs to collapse and pull away from the chest wall. This reduces the lungs' ability to inflate and deflate properly. While this injury is not common in sport, it can occur. It may be caused by trauma or penetration secondary to a rib injury. Signs and symptoms include pain in the chest region, dyspnea or difficulty breathing, deviation of the trachea, and lightheadedness. A full evaluation, including listening to lung sounds, is required. A severe pneumothorax may cause the patient to take on a blue or cyanotic appearance. Any patient with a suspected pneumothorax injury should be referred immediately by activating an emergency action plan. Lung collapse may progress to a tension pneumothorax, which is where the air trapped in the pleural cavity places tension on the heart or the other lung. This increased pressure can compromise function of these vital organs. A tension pneumothorax can cause fatal loss of oxygen due to circulatory and respiratory system compromise. Any suspected respiratory trauma warrants activation of an emergency action plan. Cardiac contusions can occur secondary to blunt trauma to the chest. Being struck by a hockey puck, baseball, or lacrosse ball is a common mechanism of injury. The contusion is caused by compression of the heart between the sternum and the rib cage. Damage to the heart can take place and can be life-threatening. Signs and symptoms may include chest pain, signs of shock, change in heart rhythm, and possible respiratory distress. Another condition, known as cardiac concussion or commotio cordis, can occur following blunt trauma. The condition presents with immediate cardiac arrest and sudden death following the injury. The injury need not to be severe enough to damage the musculoskeletal tissue to result in this fatality. Such conditions reinforce the need for an emergency action plan and the availability of trained personnel at venues where such injuries may occur. Injuries to the abdomen and thorax can range from simple muscle strains to medical emergencies. The skilled athletic trainer must be able to recognize, manage, and make appropriate referrals when dealing with abdominal and thoracic injuries. Conditions such as the female athlete triad and our discussion of mental health and well-being show the importance of an inclusive and holistic patient-centered approach. The athletic trainer who understands the need for this global view and who can become proficient in both musculoskeletal and the general medical realm will be well prepared to serve his or her patients.